Good morning or good afternoon, and welcome to the Independent Scientific Advocacy Group public meeting. So we do this meeting every week. We invite the public to ask questions and to listen to our discussion. And this week feels particularly important. We saw the news this week that the Delta variant, formerly known as B.1.617.2, that was first identified in India, has now become 99% of the cases of coronavirus in England and is rising in other parts of the UK. We also saw that when in Ireland, the Delta variant went from an estimated 5% of cases to 20% of cases in the last little while. So as has been commented, this looks like a doubling period of about a week. It looks like exponential growth. And as our government is delaying decisions, they are allowing the problem to get worse. We've heard during the week our Cornish just saying now is not the time to press the panic button, but we would like to avoid panic altogether and avoid the panic button entirely and have a rational, evidence-based conversation about what do we do to avoid disastrous situations rather than react to catastrophe, and how do we manage this situation for the health and well-being of everybody, including the economic well-being. We all want to be able to reopen again. So this is the framing for the conversation we're going to be having today. And as usual, we'll start with the situation update. And this week we'll have that from James Merrick. Thank you, James.
Thank you very much, Aoife. I was Diego Carja. And this, before we go into slides, the synopsis, is this week is increasing cases continuing in Northern Ireland, and overall case numbers steady in the past week in the Republic. But as we said, there's further things to talk about there. So we'll go into the slides, please, Ben, when you're ready. Great. So the first slide, the next slide is Northern Ireland. And as I said last week, we had this long period of sort of a slow, steady decline across the age groups in Northern Ireland. So this is daily average cases per 100,000 in the north. And we see the black is the population average. So is across the population. So as I mentioned last week, there was this uptick, and following the opening of indoor hospitality, also some Delta variant is probably part of the story, and that uptick has continued in the past week since we talked last week. And the top line there is the yellow line is 20 to 39 age group. So all age groups are rising except the two oldest age groups, 60 plus, essentially. So next slide, please, Ben. And so this is from the Department of Health in Northern Ireland. So the darker the shade of green here is the highest case of incidence. This was a snapshot earlier in the week, but Derry, Strabane, Newry, Morningdown, Belfast have been kind of the hardest hit with these increases that we saw in the previous chart. If we go to the next slide, please, then. And just to show the North in the context of the United Kingdom, as Aoife mentioned, faster rises even in a faster rate of increase in England and Scotland, and Wales at a similar rate, but at a slightly lower level than the North. As I mentioned last week, you look at somewhere like Bolton, they sort of peaked, but then somewhere like Liverpool is on a very, very steep rise. And I think we heard during the week, 99% of cases in England are now considered Delta variant, and but also mixed in and kind of relevant to our own decisions here is just the indoor hospitality. I suppose similar without ventilation guidelines or stringent ventilation guidelines or anything else like that. So the next slide, please, Ben. So that's on the Ireland's doorstep. The rapid increase across the water. This is the case numbers for Ireland again. And as I mentioned last week, we were at this kind of period of oscillating around 400, and then we came down to 300, and it's sort of in the past week or two, and it's sort of stayed at that level. I suppose following the closure of completion of the secondary school term, and we saw it drop, and of course increasing rollout of vaccines. If we go to the next slide, please, Ben. I wanted to show this slide that Professor Pagel showed us at the ISAG webinar earlier in the month. And this was for the UK at the time, but I have this circle thing. So you have this element here. We also heard the context of this slide is we also heard during this week about there's indications of increased prevalence of the Delta variant in the Republic. But someone said to me during the week, well, why are they saying that yet the overall case numbers aren't going up? And if we look at this slide here from Christina, the top line here are the overall case numbers, but underneath it, you see the non-Delta variants going down in the purple line and the Delta variant increasing at the lower line. So there's it's possible or likely that this sort of in the dotted oval here is a sort of position the Republic is in at the moment. And we kind of seen from the UK slide a moment ago where this can lead. If we go to the next slide, please, Ben. I suppose the last thing I'll mention, so great. And just the age profile. This is the age profile of cases in the Republic. There's a lot of lines here. Each line is a different age group. But the most important point is the top line. So that's the 19 to 24-year-olds. And they're at a significantly higher level than every other age group, as we can see on the slide here. The lines near zero are kind of the older age groups and very high vaccination coverage, which, that's good. But the 19 to 24-year-old group are still some way away from being vaccinated. And now I'm talking a lot about cases the past few slides, but I suppose as Professor Scally told us last week, the link between hospitalizations and cases has changed with the vaccination program, but has not been broken, at least not yet. So cases still do matter. Next slide, please, Ben. So this is the we got a little bit of data on the geographic spread. There's random news stories. There was a pop-up centre in Dundalk was on the news last night, but this came out 14-day incidence rate, and I just plotted here the counties that are higher than the national average rate. And so Limerick has had a high incidence in early June, followed by Donegal, Carlow, down to Dublin, and then somewhere like Sligo at the bottom is very low, and then all the other counties in between the national average and Sligo, just to give that sense of where things have been. And again, this is quite a lagging indicator, the 14-day incidence rate, but this was kind of the indication of the incidence in early June at least. The next slide, please, Ben. And then just the vaccine, almost both of these metrics almost show 5% in terms of the adults fully vaccinated and have received one dose. So that's great. And as we've also seen, the double dose is increasingly important in the context of the Delta variant, which, as we showed, is on the rise. Next slide, please, Ben. So the World Outlook, we showed this chart last week. There's a lot of caveats with daily confirmed cases worldwide. So the rate of decrease slowed up slightly in the past week, but it has stayed decreasing. And in the European Union, the rate of decrease has declined a little bit too, but has maintained a decrease. Just to give that international context, but one of the caveats we mentioned last week, on the next slide, please, Ben, we will highlight. So this is South Africa. And the reason South Africa is a concern is that the variant that was prevalent there earlier on in the year had increased amount of vaccine escape. And just in the past few weeks in South Africa, we're seeing this sharply rising number of cases. So again, there's this element of mixed bag, vaccine program rolling out, numbers dropping in some places, numbers rising in other places. So we're entering this period of that we'll be discussing in the webinar today of how to manage this. So thank you very much. That's the update for this week.
Thank you, James. As ever, that's very informative and illuminating. And I think it is important that we do keep track of these things. We're in, I think, a comparatively good position. You know, we're not in the situation the UK is currently in. We're in a better position, and we have the chance to react accordingly and to put in place good practices and procedures so that we don't end up in another disastrous situation, another catastrophe. And that's what we should be doing to avoid another crisis and avoid having to press the panic button, as has been mentioned already. So this afternoon, we're very lucky that we are being joined by Orla Hegarty as well, who is an architect and an assistant professor in UCD. And she has been really great over the last year and a bit in talking about, you know, what are the things we need to do to make our spaces safe. And she has contributed to a NEFIT subcommittee. She's one of the people who has been instrumental in getting CO2 monitors put into our schools for the next academic year, which is a very positive, constructive step in making these spaces safer for everybody. And so, Orla, we're delighted that you can join us today. And really, we'd just like to hear your views on what needs to be done to make our spaces safe. As you know, the government is planning this reopening of indoor hospitality. Indoor hospitality is already open in the case of hotels, but as far as I can tell, this has been done without any concrete guidelines with regard to ventilation and other factors that could actually be really important in making this a success. You're on mute, Orla, sorry.
Thanks, Aoife, and thank you very much for asking me along. I suppose where are we at? We're again sort of at the cliff edge of some major changes, I think, without having prepared for them. We had reopening last year, we had reopening in December. So effectively this is the third time round, and we're, I think, still approaching these reopenings as if you can kind of trickle through things and they're all gradual, rather than the fact that a lot of things are very low risk. And yes, we can have more activity without much impact, but some things are really high risk. And we still haven't really addressed the fact that this isn't a disease that spreads like some other diseases that are modelled, in that it is highly over dispersed. So what happens is most people with COVID don't transmit to anybody else, but when it gets into the right environmental conditions, we get explosive super spread, and we know what those conditions are. And if we look at the patterns of COVID spread in Ireland over the last year, you can see it's really clearly about the buildings. More than half of the people who died were in fewer than 400 infected in fewer than 400 buildings. They were the nursing homes. 15% of the people infected were infected in hospitals. Again, we only have maybe 80 hospital buildings, and 2/3 of the cases in workplace outbreaks have been in the meat and food production plants. Again, very specific environmental conditions, and we've had obviously spread within households and in vehicles and things as well. So I've always been of the view that rather than a hard shutdown and isolate everybody, we should be using evidence-based policy. You know, we're using evidence policy for the vaccine rollout programme, and we still seem to be a trial and error on the environmental aspects of this. So what has happened over the last number of months is that some of the low-risk areas have reopened, and you know, I was of the view that non-essential retail could probably have been open with some precautions. We have a huge advantage of weather at the moment. In the current conditions, most of our buildings are actually freely ventilated. So unless they're crowding or windows are closed, a lot of buildings are operating close to outdoor conditions in terms of ventilation. So we have a huge advantage. We have another advantage in that our secondary schools have closed and our primary schools will close shortly. So we have some strong tailwinds that are really helpful at the moment. But that isn't, that I suppose means two things to me. One is that we need to be very, very careful about indoor hospitality, and doing it again as a trial and error, I think, is a serious mistake. We've had a year of knowledge of how this spreads, why indoor dining is such high risk, and how we can mitigate it. And unfortunately for people in the sector, they are again, clearly they need to reopen, their businesses need to reopen, but doing it in a way that is trial and error risks us having super spread events and having to close again. And the worst thing that could happen for this sector is that they have to close again, whether it's in July or August or maybe September when the weather changes. That would be, really detrimental. And if they have to close in September, they're then facing into trying to do this in winter conditions when they can't have outdoor dining and we don't have that flexibility. We don't have to look very far to see how badly indoor dining can go wrong. Just recently, a restaurant in Edinburgh has had to close when 26 staff were infected. And we know that most of the people who work in this sector are unvaccinated and they're young. And we've had lots of other super spread events in these settings internationally where dozens of people have been infected. And if we track what happened here in December, clearly the seeds were also in the 3 weeks of indoor hospitality. So I have enormous sympathy for people in the sector. But I also question why 15 months in, we're still doing this on a wing and a prayer, and not using all of the knowledge we have to try and mitigate it. I'm sure some places are perfectly safe already. They should be allowed to be checked and open, and others are really dangerous and they should be remediated.
One of the things I've heard, I think from you, Orla, and from others as well, is that, with the CO2 monitor, you can set a threshold. A reasonable threshold is 800 parts per million of CO2, and I think you said that would mean that the risk of basically breathing in somebody's air is very low in that. And in the case of schools, they have purchased CO2 monitors that cost around about €50 each, if I understand correctly. These are very simple, small. They'd fit in your pocket. You can put them on a shelf. They glow green. Oh yes, there's, you have one. Yeah, exactly. They're very small. Yeah, and so having something like that, you and others were consulted for ventilation standards in schools. Was there anything to do with other commercial premises, workplaces, indoor hospitality? Was there any discussion? Were you invited to comment there, or is that ongoing?
Well, firstly, just to explain what it is, it is a proxy. We don't have equipment yet to measure virus in the air, but what we can measure is how much exhaled air is in the room. And the more exhaled air, the more chances are that there's virus in the air if somebody is breathing out virus that it is building up. So we know that outside it dilutes and blows away. Unless you're in close proximity, you're at low risk, but inside it can start to build up like smoke. So this is a way of assessing how much exhaled air is in the room. So it is a proxy. It's not measuring the actual virus, and it has its limitations, but it also has its strengths, because as humans we don't perceive these things unless the room is very stuffy and we start to feel sleepy. We don't perceive it. So this is a way of catching it at a level where we don't see it ourselves. In relation to the advice given, obviously the school sector has probably been the first. That the teachers were over ventilating all winter. It was by far the first sector to adopt ventilation and to accept airborne transmission. We still have a lot of sectors who don't accept airborne transmission or haven't translated it into their guidance. The schools did accept that from last summer, and in fairness, they led the way, and I think they kept children and teachers safe through the winter, even though it was really difficult. And yes, there were outbreaks. I think they prevented it being much worse, and they did that by probably over-ventilating and being cold. So hopefully this is a means next winter whereby they can actually manage it, because they'll measure it, and they'll start to learn in certain weather conditions what level of ventilation is needed, or if it gets dangerous, they'll take the kids outside for 15 minutes, or they'll realise that on a calm day, certain classrooms are higher risk, or staff break rooms or whatever. So it's a tool to learn. And I think it's also in the same way that the Green Flags initiative in schools had children going home and sorting their waste and turning off taps. I think it's also a way of educating families and everybody else. When you teach children, they bring it out into the community. So I think there's big advantages of the schools. For other sectors, it's really unclear as to what will be adopted. I think it's still surprising to me that the business community has waited for vaccines rather than being more proactive. We could have been on this, as I said, the teachers were on it in August. We could have been on it everywhere else. We could differentiate ourselves from other places. And the huge advantage of de-risking buildings is that it doesn't matter what variant really gets thrown at us. It doesn't really matter what future pandemic, we will be set up for it. Maybe one of the flaws at the moment, or the weaknesses, is that sectors are writing their own guidance, and clearly they don't have the scientific knowledge to do that in a rigorous way. And it also means they're compromised sometimes on what they think is practically feasible. So they hold back, and also it's inconsistent. So the guidance if you start to read across creches and construction and hospitality and retail and gyms, they're all different. They're all different, and people in each of these sectors is reading their sectoral guidance and assuming that is best practice when that isn't always the case, or that it's up to date. And I think also people aren't aware that the work safely protocol was reissued in May, and all employers have to do a risk assessment for the places of employment. And I don't think that's been said clearly enough. The Health and Safety Authority are responsible for enforcement in that area, and that document clearly says that they need to look at ventilation, and that would include PPE and everything else. So employers could be putting themselves at risk. This is not loading more regulation on them, and the last thing they need to hear this week is that there's more regulation that might catch them. But this is a regulatory framework that they are used to working in. They're used to working with safety statements and doing risk assessments for trips and falls, and staff handling chemicals and food, and this is something that's already embedded in all employers' day-to-day practices, and they need to expand that now into the conditions, and that goes for break rooms in hospitals as much as it does kitchen staff who are all on top of each other, and people out doing deliveries, people in vans in part of their work where they're in shared vehicles. Schools, it includes all employers, and I don't think that's really been explained clearly enough. And then when people do look to adopt that, I think we need to give them much more practical advice about things, rather than saying there's a 40-page document for heating engineers to go and read, and they'll just give you a quotation for overhauling your equipment, and that's more cost. Practical things like turn off your air curtains at your front door for drafts, space, if your ventilation is poor, lowering your occupancy is one way of dealing with it. If your restaurant has a high ceiling and well-spaced tables, you're probably pretty safe, but then you might be sending people into toilet areas with no ventilation, where they come into a toilet where somebody was 10 minutes ago and it's lingering in the air. Or they're sending staff into a cold room to bring out vegetables, and the cold room has virus sitting there from yesterday. So the kind of simple things and what it means, I think we need to be explaining to the people who are actually on the ground trying to run these things, and then people will instinctively start to make safer decisions, I think.
Yeah, and I think one of the things about those CO2 monitors, I find them I think it's very constructive and practical. They're small, they don't require any, piping in or anything like that. You can just sit them on a shelf. You either charge the batteries or you plug them in. One that I saw that you said was going to be in the schools, just you set the threshold, whether that's 800 parts per million or whatever, and it glows green when it's safe and it glows red when it's not. that would be very reassuring, I think, for the clientele of any hospitality venue, if that was on display on the shelf,
It's really
or
cheap.
in the bathroom.
It's very cheap technology and widely available. It's not going to catch everything, but it'll certainly give people a very strong, clear understanding, and it'll catch danger. And also, I think, this will attract customers back, apart from protecting staff. It's pretty simple to wire this up to a display screen, and they do that in Japan, and they're doing it in Washington, other places where people, before they come in, can see, and in the same way that people trust that food safety has a process and is being regulated, we don't see that as a burden. We see that as being essential. We need to see environmental health also to what we breathe. That statistic that the area of your lungs is the size of a tennis court, and you're breathing 7 or 8 liters of air every minute. That is people's exposure. That is your exposure to the virus. And to move away from hand sanitizer on every table, and wiping down chairs between customers, and things that are marginal, if not ineffective, and start to really explain to people how they catch this, and how we can get every building down to low risk. We could plan for winter that every building is low risk.
That would be cool.
That is available to us regardless of what happens with international travel, variants, vaccination problems. We have really strong tools here.
Yeah, we have been waiting for the vaccine, but sitting on our hands while we're waiting, it seems, rather than taking all these proactive steps that could make things safe in the intervening time, because, the wait for the vaccine is long, as it should be, because this takes time. I'll just remind the audience that if you want to put a question into the Q&A, please do. We'll be doing that rather than the raise hand function isn't working today for us. So if you could use the Q&A if you want to do that. I'm going to bring in some other people now. I think Jerry Colleen, would you like to come in here?
Yeah, we're so lucky to have Orla here, not just at this meeting, but in the country, and people like John Wenger. It's not that we don't have the expertise. We do have the expertise. And the only thing, I think the only 2 words I might disagree with was this, or 3 words, trial and error. I think a year ago it was trial and error. Today it's just error. We know these things are wrong. We know these things are mistakes. If I had the authority, I could walk around my town here with a clipboard, and I would probably encounter at least 20 ventilation issues that need to be corrected and could be corrected within a few days. The pop-up tents that are indoors, outdoors, the hair salons with the door closed, you can go on and on. So we have the expertise, we're not using it, and I'm just worried all across the board that we're still addicted to wishful thinking. We also, when we look across to the vaccines, we know how far they can take you. We look at Israel and we can see that their remaining outbreaks are in schools where they haven't reached with vaccines yet. But the reason they've gone so far is they adopted a vaccines plus strategy. It was rational and they were patient. Whereas, we are just currently on course for a reopening of indoor dining and international travel that has no rational technical basis. I liked your phrase, Aoife, of fairy tale epidemiology, because that's where we're headed right now. And this is not trial and error. This is just error.
Jerry, you mentioned there international travel, because this is another one that is up in, it's in many people's minds. People are thinking about it. The government are talking about it. It was not that long ago that the government told us to expect an outdoor summer and a domestic holiday. And they rather abruptly then started talking about opening indoor hospitality and having international travel again, but without discussing what needs to be done to make those things safe. Jerry, would you have a view there? And I'll come to Orla on this as well afterwards, if you're okay with that.
Sure. I think, there are ways to make these things safe. And we look at diseases that we've taken further down the track towards like heavy suppression and elimination. So there's a whole bunch of diseases that have been eliminated from this country, measles, rubella, all that kind of stuff, but it's within living memory that they were very, very common, and we didn't tolerate them. We don't tolerate them. From the variants we have so far and the vaccines that we have, which are extraordinarily efficacious, we know that even if we do fall short of herd immunity, it won't be by much. So it's always possible to nudge it over the line. So there's lots to get excited about in terms of, vaccines plus ventilation plus, careful control of travel, that we could, for example, reopen international travel across Europe very freely within this year. But we're just not there yet. And if you take that Israeli example, it's a nice example of how you can have herd immunity and it can work focally, but it can also break down focally. Like it breaks down in schools because I haven't reached them yet. And similarly, it is possible to restrict international travel to herd immunity travel. Basically all airport staff should be vaccinated, just like all, healthcare staff have to be vaccinated against Hep B. There's no debate about that. So if you have vaccinated travelers only and you have vaccinated staff only working in airports or a herd immunity terminal, then you can have pretty secure travel. But of course, we can't control where somebody is before they go to the airport and after the airport. So there will be testing, before and after testing required. But those things are achievable. But to talk about unrestricted travel, non-essential travel for unvaccinated people in 2021 is wishful thinking. It's going to get us into trouble. I wish I hadn't used that phrase Delta Plus last week because I just heard some news about it last night. I think that's shaken all of us up a little bit. So these are things that we need to learn how to do, and they can really get us out of this and into a good place this year, but we're not there yet. And frankly, July 4th really scares the hell out of me.
So, Jerry, a question came in just on that, on two things you said there. So with regard to the digital cert, I think one of the criteria there is if you had COVID within 9 months, that you're allowed travel under the digital cert. And the other question from the same person is there a metric would you propose a metric or suggest a metric for reopening EU-wide travel?
I think for me, if it's totally unrestricted, I think then as a continent, we need to get towards herd immunity. And then if we still have outbreaks ongoing, we need to snuff those out. And the sooner the better. And this is very common. It's done in many circumstances, but that can be within our grasp this year. The EU at large is still on a very positive downward trajectory. It's within our grasp. I'm just worried we're all going to blow it because we're still, we haven't learned the lessons from previous surges, and we're not. I guess most of us in Europe are not familiar with variants or pathogens that are allowed to continue evolving. Now, I know what that looks like, and I just think this concept that we should accept this as an endemic pathogen is not based on a realistic understanding of what endemic transmission of a high virulence evolving pathogen actually looks like in practice, because it ain't fun.
Yeah. Orla, a question has come in for you just regarding the CO2 monitors. There's many people asking us if there's any particular recommended brand or website or anything like that. I mean, I'm sure you don't, I know you're a totally independent person. You're not paid by anyone to plug a particular brand, but you might have a couple that about that you think are good.
I can share actually. John Wenger, who was mentioned there, who's Professor of Chemistry in UCC, did a list of, I think, brands that are available in Ireland. There's lots available on the internet as well. People should be looking for NDIR, which is the technology that assesses the CO2. So that is more accurate than some of the cheaper ones. So, and again, I don't quite know what they're available at now. I know the kind of sophisticated ones with Bluetooth and apps and things are probably up around €200, but I think you could be paying half of that, and I'm not sure, they're obviously bulk buying for the schools. I'm not sure what price they got them at. So probably somewhere from €100 up, I would think, is probably what people would be paying for basic. And I can share that list that John Wenger did, actually. But I mean, people could safely Google CO2 monitor NDIR, and they'll probably get something that is fine. I would just give a warning on that, actually, in terms of equipment and regulation. There's a lot of equipment being offered to businesses and places now as air purifiers, with all sorts of technologies of ionization and UV lighting, and that's not a regulated market, and people need to be very careful about what is being advertised and promoted. The general advice is HEPA filtration, which is basically very dumb, low-tech fan and filter, is generally what's advised. And anything more sophisticated, you really need to have independent advice about installation and effectiveness. But buying things that plug in or that pass over surfaces may not be effective. And in some cases, they produce ozone, which is damaging to lungs. So people need to be careful about any investment they're making there. And sorry, just to finish out on an earlier point, I think that Jerry made there. I think one of the barriers to some of the simple things is actually some of the sectors themselves. If we were able to say to people in hospitality, would you take the glass out of your windows for July and August? Would you invest in HEPA filter, plug-in HEPA filtration at €100 a unit for a few units in the back of the restaurant? Or would you DIY them because it's really low tech and buy a CO2 monitor? And similarly with the airlines, why don't we differentiate Ireland as being the place that has the airline industry do checklists for everything. They risk assess. They have really good practices. They work on an international basis. They understand the principles of all of this. Flying is statistically safe, but whether a plane is airworthy is the responsibility of the pilot to make that decision and to make that call. So that we look at the really high risk areas when people are getting on and off the plane, when the filtration is turned off, when people are in walkways and crowding in airports, in toilets, taking off masks to eat and drink on board. If people would engage with risk assessment, I think we could be much further down the road than saying to people, you have to be closed or you have to be open or not yet. We could be taking along a lot of these de-risking things for people in a practical way, I think.
I think that's really practical, useful advice, Orla. Like the two things you said there, that buyer beware in terms of some of these technologies. They're not regulated, and what you're saying there about the potential for Ireland to set itself apart as the first one to properly define principles and criteria for making air travel safe. And you're absolutely right that so far we've just been flipping between you're open, you're closed, you're open, you're closed. And when we first went into lockdown over a year ago now, the principle of that was initially supposed to be to buy time to put other things in place. It was the panic button, and the idea was we were pressing the panic button to buy the time to put other things in place, and we seem to have not done that. I'd like to bring in Anthony Staines here. Anthony.
I think that's an important message. WHO told us, not March of this year, but March of last year, that lockdowns were not a good way of controlling the spread of viral infections. And what they do, and they're good at this, is they buy you time to deal with the stuff. And since then, we've spent a great deal of time looking for a magic solution that was going to fix everything, preferably with no pain. And we haven't got it. And the public health message is pretty clear. None of the individual pieces are enough on their own. The vaccines we have now are brilliant. They're not enough on their own. An aggressive testing program is great, but it's not enough on its own. Antigen testing, much criticized, has got a place, but it's not enough on its own. Basic public health, contact tracing, source investigation, supporting people to isolate, that has a place. And that's probably the biggest bit we have done very little about, because we have more or less the same number of people doing that now that we had when all of this started, which is almost, given the billions we've spent in between, is almost incomprehensible. So we have to make some decisions and some choices. We've got to get all of these pieces together. If we get these pieces together, we can drive case numbers down sharply, and we can keep them down. The new variants make it more difficult. The Delta variant does spread more than the variants that are here at the moment. There's some evidence that it's a bit more severe. There is a little bit of evidence that says that the vaccines do not protect against it as well, but certainly the vaccines are very effective against it. But we put all of these things together, we can get case numbers down to a very low level. And that's a level at which the impediment in everyday life is quite small. And we've done something similar with measles. Measles is a lethal disease. Measles kills children every year. Measles pneumonia and I have treated measles pneumonia, is remarkably difficult to treat. Neurological damage from measles can be disastrous and is not treatable. But we don't see it. And we don't see it because we have now got an effective programme to control it. So the parents of Ireland don't really have to worry all that much about measles as long as they get their kids vaccinated. We want to get to the same place with COVID-19. People say all the time, you can't control this virus, you can't eliminate this virus. But that's not true. We've controlled and eliminated much worse. Yesterday, WHO tweeted that Ebola had been taken out of Guinea, that the Ebola outbreak there is over. And that's an amazing achievement for Guinea, which has not a fraction of the public health resources we have. So let's use our public health resources. Let's use the skills we have. Let's use all the things we have. It's not ventilation or vaccination or control or this or that or the other, or even mandatory hotel quarantine. It's all of these things together can produce really effective control of pretty much any airborne disease. And that's where we should be going.
I think measles is a really good example because it is a highly, highly infectious disease, much more infectious than COVID, in fact. And but we have it under control in such a way that it's eliminated from this country, and we don't have to think about it on a daily basis. And really, even though it is endemic worldwide, it is eliminated locally. And when we suggest that that might be possible for coronavirus, people think it's nonsense, but it's been demonstrated. There's a question I want to. So there has been a question about with regard to travel and the green cert, the idea that somebody who has been previously infected within the last 9 months is considered immune or equivalent in status to a vaccinated person. So this is this sensible, and might this 9 months be elongated? I would imagine that depends on data that we need to accumulate over time, and only with time we might have it. But Anthony, do you have a comment on that?
I think that's going to become clearer over time. There is no doubt you can be reinfected with this virus. There are lots of examples around the place of people who've been previously infected, who got infected again, and lots of examples of people who've been vaccinated, who get infected again. So none of the things we have are perfect. 9 months is quite a long time, but we will need to watch carefully what happens. We need to see carefully what the data show us. And as we get more information, it will become clearer. But at the moment, I think 9 months might be stretching it. There is a good bit of evidence that says that you have better immune response if you're vaccinated sometime, even after you've been infected. But if you're vaccinated sometime after the primary infection, and I'd be more reassured by that than by evidence of previous infection.
Okay. Okay. There's a question that's come in for you, Orla, which you'll see yourself if you're in a position to answer it. But this person is saying that they have a friend who is currently undergoing chemotherapy. They've had their first AstraZeneca, but not their second yet. And they're asking, is there anything this person can do to make sure that their hospital visits are safe? Can they insist, is there something they can insist that's in place if they double mask? Is that going to be something? I mean, obviously this is a rather generic question. You haven't seen the room they're going into or something, but the questioner says that, there's no opening windows in the room they're going into. Is there anything somebody in that kind of position can do? Or maybe it's too difficult if you're the patient, it needs to happen at a different level.
Yeah, well, I mean, firstly, if you're the patient, it's difficult because you can't control what masks the staff are wearing, and a lot of healthcare workers are still wearing surgical masks when really they should be wearing respirator masks that give protection for airborne viruses. If you are a patient, I suppose the first thing you can do is you might think about wearing a mask yourself when you're moving around or using toilets or sharing spaces. If you can't control ventilation that you can see, like in opening windows, if you're in a very modern hospital, you'll probably have very good air change and filtration through the system. In modern hospitals have 6 or 12 air changes per hour, and maybe the reason that the medical profession don't see airborne is because of that. Older buildings and converted buildings obviously are much higher risk because they may have been sealed up and the ventilation or the system mightn't be adequate. I think the other thing somebody can do, they might want to invest in a filtration, and HEPA filtration that they plug in and they bring with them if they're going to be in hospital or in a setting where they're getting treatment, and you can buy them from probably about €120 up. It's a small I don't have one right beside me now, but we're talking something maybe 1.5 foot high that plugs in, that pulls the air in the space through 4 or 5 times an hour. So this won't be picked up on CO2 monitoring. So CO2 monitoring might be reading quite a high reading, but the air in the room is being pulled through a very fine filter that is removing particles, including dust and pollen and viral particles. So you can supplement poor ventilation with filtration. And I think that's probably an option for the hospitality sector as well.
Yeah.
If you're putting filtration around the room, or as somebody has suggested, they maybe even start designing units into tables where across the table you're getting filtered air. There's all sorts of other health benefits to that. But this is really low technology, so we need to be using it. So I mean, if somebody has the resources to afford that and they're going to be in a hospital room or in a treatment room for chemotherapy or something, they might think about investing in that, and they might think about getting themselves some better quality masks and making sure that the fit on the mask is good. So the mask is doing 2 things: it's filtration and fit. So you need to think about both. People with surgical masks often have filtration, but the fit isn't good, so it's leaky. A surgical mask with a cloth mask on top will give quite a tight fit. So double masking has been proven to be quite effective. So if people can't get a respirator mask that's well fit, but a double masking with a surgical mask and then a cloth mask to give a better fit is apparently very effective.
Thank you, Orla. That's very useful advice. I think I want to get a HEPA filter for myself now. I'll carry it with me everywhere. And because we are also thinking,
and lots of people I know got through Christmas by getting HEPA filtration. Yeah.
Okay, very good. Yeah. Now that's, and I'm even thinking ahead of, like I said, the next academic year. The lecture theatre that we usually use, we didn't use it at all last year, but the one we usually use is in the basement, and it gets stuffy. So I don't even need to go in with the CO2 monitor to know if that's well ventilated or not. I've felt it as a stuffy room. So yeah, something like a HEPA filter, that's going to be very practical, very useful advice. Thank you for that, Orla. So some other questions. So somebody has asked, Orla, again for you, you're in high demand today. We're delighted to have you. Can inside an aircraft be made safe? Is this another case for a HEPA filter?
Yeah, you see, I mean, what I've been reading what it seems to be is that aircraft have about 50% fresh air and 50% filtered air. Okay, so the risk there is we don't know how good the filtration is and whether it's been maintained, whether it's on, and how close it is to somebody who needs it. So the filtration might be great, but you might be in the same row as somebody who's breathing out virus, and by the time it gets to the filter and back to you, it's too late. I think we need to firstly get more information. Older aircraft, I think, don't have the same level of filtration and maintenance. The other problem with aircraft is we sit very close to other people, so the masking is really, really important, and people, as we know, are taking off masks to eat and drink on aircraft. The other problem is you'll see the airline industry saying, well, air moves in straight lines, it comes down, it gets filtered, it comes back. It doesn't move in straight lines. Everybody has an individual fan over their seat that they adjust, so that changes the air movement patterns. People walk up and down the aisle, people open the front and back doors, toilet doors, cockpit doors gets opened. All of this changes the movement of air in the space. So I think we need to move past saying it's safe and saying, okay, where are the specific risk areas and how do we tackle them? And to me, it would be starting, in the terminal building, looking at how people are boarding, looking at how they're seated and how they're separated, then looking at how they behave within the flight, because if one person is shedding virus and they walk up the aisle to use the bathroom and then they're in the bathroom for a few minutes and they close the door and come back, you have conditions that has happened on flights where one person can infect many people, and the virus can be hanging in the air in the toilet. So I think we need to, there's a whole level of education to happen so that people who work in that sector understand this, and that people who get on the plane know why they're being asked to wear a mask or to sit in a certain place or whatever. But we haven't really, I don't see information that has engaged with that yet.
Yeah. You've anticipated a question. We have a question from Aoife O'Brien, who writes for the Times Ireland, and she was essentially asking, once the digital cert comes in, what can we do to ensure the safety of travel? And I think you've anticipated that really there. There's things that need to be brought in terms of what happens in the terminal, what happens inside the plane. I think even what you're talking about there, with greater public information, you would effectively get a social pressure to keep your mask on as well. If people were aware that the fact, you're in a place with shared air is a huge problem when it comes to transmission of this virus. And if anybody's taken just abandon the food and drink service part of the flight, and eat before you go on and have your drink before you go on, those kind of things, your drink of water, whatever it is you need to keep hydrated. And those things are going to make a big difference by the sound of things. So that's really useful, practical advice. Thank you, Orla. So I've got another one here about air filtration on aircraft. Is this is the opinion, I suppose they mean your opinion, Orla, on air filtration in aircraft in line with studies carried out by the FAA and ICAO? What would be successful in terms of mitigating specific risks? Would antigen testing prior to airport entry help minimize risks?
I'm not familiar with either of those two studies. I know there's been lots put out. I mean, it's the same with every sector, though. We need to be careful about research that's put out and who's commissioned it and what conditions it was produced in. There's any number of studies that'll prove anything at the moment, and not to say that these are those, but we need to be careful. I'm thinking of the experiment in Liverpool recently about indoor spaces where they just didn't follow up with people, and then they say, well, nobody got COVID. Whereas Germany had done a really good one last summer, where they did follow up with everybody, and they had really good masking and ventilation protocols, and they ran an indoor venue very successfully, and that is published as something we could use. So we need to use the ones that are valid and not the ones maybe that are marketing. Ireland has an opportunity, I think, to differentiate itself as well. Like, why don't we decide to take a lead on this? Maybe it's going to mean planes are more expensive to run because we do full fresh air rather than filtered air. Maybe it means the occupancy is going to be reduced for the next year. all of these things, and some of the risk with flying at the moment isn't the flight, it's that somebody will come in with another variant we've never heard of and go to a restaurant next week, and before we know about it, it's 2 weeks later and there's 100 cases. If we can mitigate that risk by dealing with the restaurants, so that if people do come in with a new variant, it trickles along and it doesn't explode. So that we manage the high risk buildings, so that person doesn't go to work in a meat plant, doesn't go to work in a nursing home, doesn't go to work in a restaurant, or to sit in a pub for the evening. If we target the places where we might get super spread, or where we know we have had these conditions, if people do come in on a flight with a variant, we won't have a major problem within a short space of time.
Yeah. Now this is, Orla, you speak such sense, and everything you say is so practical and actionable. And it's really criminal that this hasn't been done. We're talking about opening indoor hospitality in a week and a bit. And, we have not done anything to make those spaces safe. We have just
with a substantially unvaccinated population who will be working there. It's easy for us, I think, to think about, I'll be sitting at a table with my 4 friends for the evening, and to manage our own risk to some extent. You're forgetting that there are people doing 8, 10 and longer shifts in surgical masks, going in and out of kitchens where there could be 10 people working in closed space. And they're more likely to be the people who are all unvaccinated and maybe living in overcrowded conditions in house shares and, those kind of settings. So through no fault of their own, we are putting them at enormous risk to keep their job and to pay their rent, for the luxury of people who can choose to go to have a meal with their friends. I think there's an element of ethics in all of this too. Just because those of us who are vaccinated now are feeling a little bit more comfortable, we shouldn't assume that we can put other people in 2, 3, 4 times the danger they were in April.
Yeah, and I think we already know that they're talking about winding down the PUP payment before these individuals will have received their vaccine. So they'll be economically compelled to return to work. I'd like to bring in Claire Kelly here, because Claire Kelly, I think, has some interesting, very useful views on this exact topic of, how we're treating young people through this whole pandemic.
Thanks, Aoife. Well, I think, Orla has hit the nail on the head. And I suppose I just wanted to comment or emphasize that point, that this is it's a matter of ethics, and it does seem to be, there seems to be a bit of an empathy deficit at the moment amongst, large parts of the population, particularly those who are fully or partially or on their way to being fully vaccinated, towards the young people of the country, so those aged under 30 who are not currently vaccinated and can't hope to be until maybe late August or even September for those who are closer to 20. Yet these are the people who are expected to serve the pints and the cocktails and dinners, who are, being berated for supposedly choosing the pup over working in these minimum wage, long hours, antisocial hours jobs. Which involve, as Orla has just outlined, serving people who are unmasked because they're eating and drinking in questionably ventilated conditions. We really need to do the things that Orla has outlined in order to make these spaces and jobs safe for those who work in them, instead of just, giving out to the people who, in our opinion, are deciding not to take those jobs. We have to remember that, our young people have been deprived of, most social opportunities for about 18 months now. And these social opportunities are enormously important to their development as emerging adults. I think we also need to think, or I'd ask our leaders and advisors to think about the contradiction that's inherent to, telling young people that they shouldn't take an international holiday once those are permitted, but that they should go and work in a bar or a restaurant and be exposed to the kinds of risks that we've talked about. and I think there's also, a kind of a lack of empathy inherent to this narrative that young people are essentially unaffected by COVID. So even if they get COVID, they'll be fine. All that matters is hospitalization and death. Even though, as we've talked about in these meetings, there's the very real and substantial risk of long COVID that we don't fully understand or know how to treat. So, I think like one of the things that I suppose I wanted to raise as well at the end is one of as this pandemic has gone on and we're being continually challenged, by these new threats, by the variant, and people are, frustrated that they're the chance of returning to normality may be threatened. There's also somewhat of an increasing polarization that's happening. We saw this week, for example, that people are kind of split down the middle now in terms of the extent to which they think we're reopening too quickly versus too slowly. And that kind of polarization, which can be really stoked by the media, and can be kind of, used by political leaders to their benefit. It's really bad for empathy, and it's really bad for an effective and cooperative response to public health directives when we need them. And we should, if we've learned anything, we should know by now that this virus can continue to surprise us. And as Anthony, just talked about, there's no one magic trick that's going to get us out of this. We need, we need to use all of the tools at our disposal, and we need to work together. And so we need to speak to people's cooperative instincts rather than sowing division, so that we're in a good position to deal with whatever is coming next.
Yeah, thank you, Claire. Yes, I think very important points, all of those points you've raised. And it is really true that young people have been mistreated really throughout this in terms of just dismissing and disregarding their personal risks in terms of the risk of what happens to them when they get infected, and then also, what happens to them when we resume what we feel is normal activity. I'd like to bring in Ivan Perry now. Ivan, you had a couple of points you wanted to make, and I think there's some questions from the audience that are also relevant for you.
Yeah, no,
I'll get them in a moment. Yeah.
First of all, just to thank Orla for a really interesting and informative presentation. It's so good to have a calm discussion instead of a lot of what passes in the media for these contrived back and forth debates. And in particular, it's unfortunate that the hospitality and the aviation industry, who've gone down this cul-de-sac of antigen testing, which, as we know, is a good red light technology, helpful when it's positive, but is not really helpful as a green light technology in terms of giving people permission to do stuff like going to restaurants or boarding planes. So I think it's a pity that these sectors haven't taken on board the very practical suggestions you've made, like taking out windows and putting in air filters and so on. And one thing I wanted to ask you is that, have you had much engagement with the local authority and environmental health officers? Because these are a highly skilled group of individuals, and I feel that the skills that they're not being deployed as effectively as they might be to help us address some of these issues. So I suppose I'm just wondering, Orla, if this is something that, if you've had any in engagement with the local authority and environmental health officers.
Would you like me to respond to that? Yeah, I think things are split all over the place. Like on one level, we have the Gardaí expected to measure distance between tables almost and crowding, without really being given advice about what they're trying to achieve. Rather than a rule, what's the goal here? We have health and safety officers who are responsible for staff welfare, and again their resources are spread quite thinly. And then we have environmental health people who predominantly are dealing with food safety and those kind of issues. It always strikes me that there were 900 contact tracers on phones at one stage, and yet I don't know that there was any team of prevention in parallel. Chicago's in the flu pandemic is a really interesting one I've looked at, because they took public health
1918 Spanish flu, yeah.
1918.
Sorry, yeah.
Chicago had one wave of Spanish flu. They spent 6 weeks fixing up their buildings where people assembled, so meeting halls, restaurants, theatres, cinemas. Their public transport was streetcars, all of that, a lot of activity to clean, ventilate and open, and they didn't have a second wave. They hit that very hard, but they had I think 150 building inspectors on the ground who were going door to door explaining to people what they needed to do, and then giving them a license to reopen. That's 150 people might feel like a lot. That was a city of probably double the population of Ireland, so that's not huge. And in the scale of the contact tracing operation, for example, that's nothing. It's not a lot. San Francisco at the moment have posters in business windows, which seems like another good idea. So somebody comes along and brings a CO2 monitor and walks around, who understands buildings, points out your areas of risk and things you need to do. And then there's a poster in the window that says this premises has mechanical ventilation, or this premises has to have the windows open, or this premise is allowed to have an occupancy of 30 people, or whatever else it is. So you can actually give confidence to your customers, but also there's an independent enforcement then, because somebody can come along and say, well, actually there were 50 people here, you were supposed to have 30. So it's enforceable, and really I think the hospitality sector have to buy into independent enforcement here in all their interests. And I don't mean that that's a heavy-handed policing, but if there are some weak operators who are taking advantage, they could pull the whole sector down into another closure. It's in everybody's interest that the people who are really diligent and really need to be open are leading the way, and that the people who aren't are penalised or shut down or are given time to remediate or whatever else it is. I don't think the self-certification we rely on so much in Ireland is effective, and it's too high a risk at the moment. We don't do that for food safety. We don't say to people anybody can serve food, and if somebody gets sick they can sue them afterwards. That's a public health risk to the entire community and our health service. So we regulate it, and we send inspectors around to look for vermin and to see if the food is fresh. And so the principles are all there, but at the moment we don't have an infrastructure for that.
Yeah, because in a way, the environmental health officers are very relevant to the food sector, because as you say, restaurants are used to dealing with the environmental health officers. They have the authority to walk into a restaurant and close it if they're not happy with the standards. And I think that there's a resource there and they're highly skilled, trained professionals, and there's a resource there that we don't seem to be using, and particularly just to impose core minimum standards.
Yeah, and we're talking about hospitality now because it's the sharp, situation we're in. But this equally applies to HICWA and the nursing homes for September. It equally applies to the Department of Agriculture and the meat plants. It requires the Department of Education and schools. It's in everybody's interest now that we put an infrastructure there for these high-risk places. And transport, obviously, clearly, aviation we're talking about, but buses, trams and trains as well. We want to get back to higher occupancy on public transport vehicles. So that has to be addressed as well. We can't continue to operate at very low occupancy.
So this is really great. I see Jerry raising his hand there, and I also have some questions I'd like to get to. If we can try to get to all of the questions before we don't want to drag on too long, we'll test people's patience. But Jerry.
Yeah, just like I said, I really agree with that point, and that's about the role of environmental health officers, and that's how cholera epidemics are managed in, the unlucky part of the world that has them regularly. It's And this is not a job for the guards. And certainly in Africa and across the tropics, it's not a job for the police. Somebody turns up at your little informant stall where you sell chips. If you don't have the fly screen up, the clipboard comes out. You're fined, you're closed down. If you take issue with the officer, then it's a job for the police. But it's just a job for small numbers of people with clipboards. Certainly in the settings I'm used to, it's people with junior cert education and maybe a diploma, and it works. And we do see cholera epidemics eliminated. It's amazing how fast the fly screen goes up. It just works. I just want to talk about vulnerability.
Confidence.
No,
also
absolutely.
instills confidence. If you were a potential customer of these places, you'd be much happier. You're much happier eating food from a place has passed the food safety, adheres to the food safety guidelines in the kitchen. You don't have to inspect it yourself. This is happening. And if you know that these other mitigating steps are in place in a given bar or restaurant or hotel or whatever, be much more confident to be a customer of that place. And, if these places open and, some of them have these technologies and other ones don't, I know which one I'd rather go to. And I don't think I'm unusual in that regard. So I'll have a few questions I'd like to get through. Some of them are quicker than others, so I'll try and do the quick ones. One person has asked, why do we think there is a reluctance by decision makers, government, for example, to acknowledge that this is an airborne virus? That's not an easy question to answer, but perhaps does anybody have a view? Or Orla, would you have a view there? I don't know if you...
A really difficult one, I think partly, and understandably at the time it was an emergency medical response to something completely unknown, unprecedented in this country of, protect the hospitals, protect the health sector. And that maybe was the mission statement. And maybe we didn't move on from that. I think it really needs multidisciplinary teams making these decisions in a much more inclusive and open way. On some level, I've made this point before. I think the science hasn't failed us, either on the vaccine science or the treatment science or the environmental science. People haven't failed us in terms of doing what's been asked of them every single time and really making sacrifices. Resources haven't failed us. The money has been available, and yet it seems to be the decision-making structures that maybe are the weak link in terms of what information is being used, whether it's independent, whether it's scientific, whether it's influenced by vested interests, and it's not always clear where these decisions are being made.
That's a really well put, Orla. I think that's a wonderful point. Anthony, you wanted to come in there?
I think one thing to bear in mind is that when this started, nobody really knew what it was. So everyone treated it as if it was flu. And we obviously all knew it wasn't, but that was the plan that was there, was ready to roll. There's been a great reluctance to roll back from that. So at the beginning, NEFIT came out very strongly against masks. And HSE now recommends face coverings, not masks, which I think is an interesting insight into the psychology at play. So there's reluctance to say our original perception was not 100%. We need to change. And that's been a recurring mistake, not just in Ireland, but in many places.
No, not just in Ireland. And we could learn a lot from some Asian countries who have approached that quite differently. I mean, on a lot of levels, we sort of need to say more loudly, this is a preventable disease. And we actually have a whole toolbox of preventions to deal with it. And we're not using them.
Yeah. No, and when we hear things like the government saying they'll wait to see the hospital case numbers before making a decision, they're waiting until after people are sick before acting on a preventable disease. That's that's what you do for other diseases where you need more resources. If you get more people affected, like if it's cancer or heart disease and things like that, yes, expand those units of the hospital. This is something where you don't want people to get as far as hospital. You want to intervene before that point. I have a question about if somebody would like to comment on the announcement made from India about the Delta Plus variant. Is this something, Anthony, would you be able to give a comment on that?
Yeah, I can say a little bit about it. I mean, I'm not a virologist, but my understanding is that this is pretty much what you expect. It seems to be the nature of this disease that as you go along, you generate more variants. In cases, the greater the risk that somebody will have the virus in them for a long time and will generate a new variant. Most of the new variants, you never hear about them. But if we have enough millions of people getting sick, and enough people being sick for long enough, we will get new variants. And there's been a narrative that it's inevitable these new variants will be less severe, less transmissible, less infectious than the previous ones. And there's really no evidence for that. The evidence suggests it can go either way, and it's more likely to go in the more transmissible direction rather than the less transmissible direction. So what we're seeing is not unexpected.
Yeah. And when this has happened multiple times now, multiple times we've seen a more transmissible variant emerge. We've also seen multiple times a variant with some element, some small degree, happily so far, of vaccine escape. We shouldn't be betting everything on this not happening again. It's a foolish strategy. We also have a question about booster vaccines. How often should they be given if available? I wonder, I don't know if there is actually data on this yet. Ivan, is that something you could comment on?
Yeah, sure. No, I think that I think the answer is we actually don't know how often the booster vaccines will be needed. And of course, if we have more and more variants, as Anthony has just discussed, we'll need to continually retweak the existing vaccines. And of course, we have to be realistic that when we do get into we're likely to have, I suppose, it's likely that we'd settle down into a position where we're having maybe a booster vaccine every winter. And it's also likely that the uptake of these vaccines will gradually decline. So then we will still need to keep some of the other broad swathe of public health measures that we've been talking about, especially the ventilation, to take one example. So we will need that core multiple layers of protection that we've been talking about going into the future. Perhaps not at the current level of intensity, but they will be needed.
But the ventilation standards, like the monitoring and the HEPA filters and these kind of things that Orla has talked about, they're so practical and so available to us. These are, as she has said, they're not super high tech. They're relatively low tech, and therefore they're quite cheap tech. I would like to see those personally. I'd like to see those in place indefinitely. I would like the restaurants I go into to be well ventilated. So coronavirus and COVID is an immediate, urgent concern, but other kinds of respiratory illnesses are not pleasant either, and for a certain number of people are reasonably dangerous. It seems like a win-win here. We can do this for now and we can keep it for the future because we'll all benefit from that in the long run. So as you say, we can anticipate that the vaccine enthusiasm will wane over time. We won't have people queuing for 4 hours to get a vaccine in less, urgent times. But we can have these other things which are just good practice in general, and I think are good building design. We have a question from Eva. Sorry, go ahead.
I was just going to say, and of course, we need to continue maintain a high level of public health preparedness. We need to, continue our investment in our local public health departments because they will be needed to respond to the inevitable outbreaks that we can expect, unfortunately.
And of the new pandemics, this quote from Larry Brilliant, it's always relevant. It's always worth repeating. Outbreaks are inevitable. Pandemics are optional. There will be further outbreaks of new viruses, and how we react to them is going to make all the difference. And we ought to not let this happen again. We have to learn from this. So Aoife O'Brien from the Times Ireland has asked a question about if the government does go ahead with the indoor hospitality reopening on the 5th of July without putting in place any ventilation standards, which is the current situation, how quickly do we expect the cases to rise? Do we have any idea at what levels that will happen? And then hospitalizations as well. So Orla, would you like to come in on that?
Well, I'm only doing rough science. As people say, I've only been an epidemiologist since last April. But if we look at Northern Ireland, and we look at Scotland, and we look at Dublin, Ireland in December, there's a really clear pattern: 10 days to 2 weeks after indoor dining, cases doubled. It's really, there's
and I think it's
and
it's important that it's still happening in Northern Ireland, even in the context of vaccination, because of course vaccination is not completed yet.
Well, to balance that, we have a kind of natural experiment that happened in Ireland in between mid-September and mid-October. Dublin had everything open except indoor dining. So we had household visits, schools, shops, and people in their workplaces. And the increase in cases was actually very low. And if you looked at the rest of Ireland, when they did have indoor dining open, in the same period from mid-September to mid-October, the cases rose exponentially. Everybody wants to be back in indoor hospitality, but we have very clear indications that is a really high-risk sector for a very rapid increase in spread.
Yeah, and with regard to hospitalizations, what we've heard from the UK, there was some statement, I think, a few weeks back where they said the link between cases and hospitalizations is broken, but it's not broken by vaccination, it's changed. I think now they say it is about 4%. It seems to be pretty consistent that it's about 4% of cases end up being hospitalized. So, the vaccines are working and they're doing a great job, but they work when they're delivered to people and when they're in people's arms. We have a question here. Is it not the case that in Ireland our entire strategy is based around what the hospitals can handle? The case increases are inevitable with opening, and the government strategy is they're anticipating what can the hospitals handle. And in Ireland, we have one of the lowest number of hospital and ICU beds per capita relative to other countries in Europe. So then we see consequently that the rest of Europe can open in a way that we cannot. And we're looking at them and, wondering why we can't do the same. So we have the unvaccinated young people who are working, as we mentioned already, in hospitality, but also when we get back to schools, we will have, I suppose, some of our teachers still unvaccinated because they'll be quite young, and their students will be unvaccinated. Is this something, maybe, I don't know, Anthony, would you be willing to comment on that, the hospital capacity strategy?
Yeah, I can say a little about it. I mean, the good news is that vaccination reduces the risk of hospitalization at any given number of cases. The bad news is that even at high levels of vaccination, you can still get a lot of cases, and our hospital system is stretched. We see every year with influenza in the winter, there's a major stress in the hospital system, and we certainly don't want to add endemic COVID to that. I don't think your description of we've been driven by hospital capacity is unfair, but we do need to keep in mind that a lot of the other problems COVID causes do not get into hospitals. We have a lot of people with long COVID, and my bet is still the economic cost of COVID will be dominated by long COVID, not by the acute illness. I hope I'm wrong, but that's my thought at the moment. So is it a good strategy? No, it's not a good strategy. It's a terrible strategy, because what it does is you have a hospital system which is stretched to the limit. You have a very underdeveloped community care and primary care system, and we are just not delivering a whole load of care. And as the hospitals fill up again with COVID, we will be back not delivering a whole lot of care again. And there's no upside to that. I mean, why would you do that?
Yeah. No, I think it's a disastrous situation, and the effect on other delivery of other healthcare, as you've mentioned there, is really tragic. And as we know, specifically the Irish hospital system is already hugely stressed out by the malware attack, which has still not been fully resolved. And so I think it's a system that's under huge strain already. And so I think adding anything more to that is just crazy. Jerry, do you want to come in quickly? I'd like to wrap up soon as well. So I see we've gone on long, but it's been such a good conversation.
Yeah, just briefly, just talking about the choices ahead of us in the days ahead, and then the question about new variants. We're at a point in time where we have an opportunity to learn how to deal with this. Delta is not uncontainable, but it's getting close enough. And the things that will come afterwards, they won't be any friendlier. We learned how to keep P1 out. We did that. We just couldn't, seize the nettle when it came to our nearest neighbors. Then we got B117, which we know now as Alpha. And so we failed to learn on that occasion. We still have a little bit of time left to show we have it in us to protect us against Delta. But, I just think it might be our last experience to learn with something that's not completely beyond us, because none of us know where this goes next. It might all work out very well. There might be nothing worse than Delta, but all the best virologists whose work I read, they say otherwise. And that's one of the reasons I think we need to be very, very careful with intermediate, mediocre vaccine coverage. We need to be very careful with mediocre vaccines. We need to be very careful of looking after our vulnerable people, because that's where, first of all, they're our friends, neighbors, and relatives. But secondly, this is where new variants come from. They come from people whose immune systems aren't working so well. All the variants we have seem to have this history in their backgrounds. And we need to be very careful with natural immunity, because that's usually weakish, short-lived, and quite variant-specific. And all the existing variants have come out of populations with high levels of natural immunity. And then we don't know what's ahead. In principle, the most dangerous part in the evolutionary trajectory of a new pathogen is when it comes under pressure from a new vaccine. And that's a process we want to get through as fast as possible and as decisively as possible, but also be prepared for the fact that, there are worse things that come along, and we need to learn how to deal with them now with the variants that we're dealing with today.
And I think, and what you're saying there with regard to the evolutionary pressure, essentially, for vaccine evasion in the context of a highly vaccinated population, that's where using these other measures to keep numbers low while we are vaccinating is really, really important, because we remove that. We don't put that evolutionary filter, that natural selection filter on the virus if we keep the cases down. So that's just an extra reason. There's one last question I want to just quickly answer, because I think it's an important one. And then I think we should wrap up, because we're nearly at an hour and a half now. And I think that's testing the limits of people's attention spans. But there's a question that come in saying, if deaths and hospitalizations are significantly down due to vaccinations, why does it matter if cases go up? Excuse me. And I think this is a very important question, because I think there's a significant misunderstanding there that's common, in that, when we have a really highly infectious variant, as we do now, what will happen is if the percentage is small, like if it's 4% of people end up hospitalized as compared to a higher percentage, the problem is when you have a huge number of cases, and with a highly infectious variant, what will happen is with the relaxation and without any mitigating strategies, this will spread to infect a huge number of people in the population very, very quickly. And what that means is, even if it's a small percentage, it's going to be a large number. And I think there's a very counterintuitive thing about the way this works, in terms of which is worse, a more infectious variant or a more lethal variant. And most people will instinctively say it's the more lethal one that's worse. But actually, if you double the fatality rate, or if you increase the infectiousness by 50%, which one's worse? Well, actually, more people end up dead by increasing the infectiousness, because you get so many more cases, and this extremely large number of cases, a small percentage of that is still a large number. And that's why it's still a problem. And until we get the herd immunity levels of vaccination, we're still vulnerable. And of course, the individuals who were most vulnerable before vaccination are still most vulnerable after vaccination. Some of those the vaccine, because part of their vulnerability may be, for example, to do with how well their immune system functions. They may be immunosuppressed. So those individuals have not quite the same chance of success for the vaccine as for somebody else. So these are all reasons why we need to pay attention to this. So we've got to an hour and a half now, and I think we've had a really, really wonderful conversation. I really want to thank Orla Hegarty. You've made an amazing contribution. I think the things you've said, what you've talked about are very practical, evidence-based, and really actionable solutions that can achieve what everybody wants to achieve. We want to be able to open again. We want to be able to have many of our normal activities back again, but we also want to avoid the illness and death and all of the stresses on the hospital system and all of the suffering that goes along with that, the disruption to education, the disruption to the economy. And the kind of things you're talking about are things that are actionable and achievable and inexpensive in the grand scale of things, especially in what has been a very expensive year in terms of all of the other things we've had to do. So it's been a really wonderful contribution. I'm so glad you could join us today, Orla. It's been really valuable. And I think there's a lot of things to be taken from today in terms of the value of CO2 monitoring for any indoor places, the HEPA filters in indoor places as well. I think this should be not only hospitality venues, but also workplaces that would be really good. And then, how should we be thinking as we look forward? What should we be thinking of? And I think the model of measles, or the example of measles that was mentioned earlier, is a really good one. So measles is a very, very infectious disease. It is a fatal disease, but the people it affects worse are the infants under 1 year old who are not eligible to be vaccinated. And so we have a huge monitoring and vaccination program that is agreed almost globally. There are international agreements, in terms of how to manage this. And it's done to such an extent that we don't need to feel it or think about it on a daily basis. So we have an infectious disease that is endemic globally. It is eliminated from our country and from other countries. And this is what we should be trying to achieve with COVID. When we achieve this, we do not need to think about it anymore. It will not be in my mind or your mind as an ordinary person, but there will be the public health doctors and these public health units and all of these things that will have protocols and procedures in place so that we don't need to think about it. And this is what we need to be doing for COVID. And we need to be thinking ahead and planning ahead well for how we deal with future pandemics so we don't end up in this situation again. So thank you to everybody for your contributions today. Thank you to the audience as ever for listening and for some very, very interesting and important questions. We kept you quite long, but I think it was a particularly interesting conversation. I definitely really enjoyed it, and I learned a lot from Orla. So thank you so much, Orla. You've been really fantastic, and we're so grateful for your time. So thank you, everybody, and goodbye, and see you next time. The room, but I'm so glad you were able to join us today, Orla. That was fantastic.